core business systems enhance administrative tasks within healthcare organizations. So core business systems provide the framework for reimbursement, support of best practices, quality control, and resource allocation. So there's 4 common core business systems: admission, discharge, and transfer, financial, acuity, and scheduling systems. And acuity is a big one, especially when you're an inpatient, when it comes to your staffing. So I would say that that's probably the one that we tend to be a little more familiar with and truly really understand. So the admission, discharge, and transfer system. This contains groundwork for other types of healthcare information system because it includes, patient's name, medical record, visit or account number, demographic information, and then their central source for collecting this type of patient information and communicating it and interfacing it in the different systems, so both clinical and business. So even though somebody has a medical record, you have to establish them in real time during their admission. And the same for transferring to make sure that it gets interfaced in the proper system. And so it's as easy as, okay, you were in the OR, and now your records need to reflect that you are in med-surg so that your food gets delivered to the right unit. The financial system it manages the expenses and revenue for providing health care. This is really important because even though billing is a pain, if we don't do this right, we can't be paid and we can't have a hospital. So financial systems interface to share information with materials management. Okay, your unit had 90 bags of saline. We were charged for 46. That means you're missing 54. And so materials management will know we're 54 bags of normal saline short. We need to order more, and this is coming from this budget. And so these systems report fiscal outcomes in order to track them against your organizational goals. That's important. And as much as we hate to talk about money, and money shouldn't be the biggest factor and all that, it does, because it also drives our quality and our improvement. Healthcare is expensive regardless of what you do, and trying to make sure that costs stay down is integral in being able to have proper staffing, to be able to hire new nurses, to afford education, and to be able to spread the resources equitably among the population. So they are one of the major decision-making factors as healthcare institutions and prepare for fiscal budget. If the budget doesn't get hit, maybe we're not going to have a mobile mammogram system, and that's going to affect how many people, and is it going to drive up costs 10 years down the road due to undiagnosed cancer? So they play pivotal roles in determining the strategic direction for an organization. And the acuity system, it calculates nursing care requirements. People come to the hospital for nursing care. So it's going to equate for how many beds do we need that are bariatric? How many beds do we need that can roll and transfer from area to area because they're that sick? Do we need more specialty equipment? If you have 6 LVADs in the hospital, but your acuity reads that on average you have 12 heart failure patients that might require VADs, you're going to need more. And so it helps determine the amount of daily nursing care needed, including equipment. And then scheduling system. I mean, seriously, scheduling, it's a pain, but also very important. And it doesn't just track staff schedules, but also when things need to be serviced, equipment, allocation of patient beds, when patients can come in. It helps you track resources. So order entry system, CPOE, computer processed order entry system, or something like that. This is one of the most important systems we use. It is hard to do quickly, but it does organize it, and it very quickly tracks cost, which is really nice. So these systems automate the way that orders have traditionally been initiated for patients. It provides major safeguards by ensuring that orders are legible, provider orders, not just patient, complete, thereby providing a level of patient safety that was historically missing. And there's lots of hard and soft stops within the order entry system that ensures safety when things are being ordered, which is nice. So patient care support systems, most specialty disciplines within healthcare have an associated patient care information system, and these focus on collecting data and disseminating information related to care. So Clinical document systems, also known as clinical information system, we talked about a little bit. They're commonly used type of patient care support systems within an organization, and they're designed to collect patient data in real time instead of post time, and then we can use that quite quickly into our, like I said, it's always a feedback loop and constantly improving. And so, okay, how many vital signs were missed during this time? We can track that in real time and realize, well, where is the disconnect? Do we need more automated vital sign taking capabilities? Do we need to hire more techs? Do we need to give our nurses a break so they can check vital signs? That's something that can be used in the care support system. So pharmacy information systems, they also become mainstream patient care support, and they allow pharmacists to order, manage, and dispense medications for a facility. And it actually goes even further than that. In primary care, most pharmacists now are doctorally trained, so it's a terminal degree. And we have these collaborating agreements with them to be involved in their charts so that they can help better manage chronic disease. So one pharmacist can order, manage, and dispense medications for a facility in a sense like, okay, this is the heart failure floor, so I'm going to make sure I have lots of Lasix, and I'm going to track the Lasix use, and I'm going to order it on my own prerogative, and I'm going to make sure it's stored there. Where I work, I have a lot of diabetics, and I tend to use a lot of oral agents before I get them onto insulin. So when I came and took over my clinic, my pharmacist tracked what I tended to order, and she started to make sure she had it in stock. And she took away things that I rarely ordered, like old-fashioned calcium channel blockers. I'm not comfortable with them. I don't use them anymore because they're not part of the guidelines, whereas the old doctor used them because he was most comfortable with it. And so that's part of that. And then another cool thing is a pharmacist now, and this can happen in patient too, which is great, is they look and say, okay, you have this patient and they're on the methotrexate. Let's check, a folate level and make sure they're getting vitamin B12 and folate and get their eyes checked. And that's all based on a pharmacist, and it's from an operating system. So laboratory support system. They were the first systems ever used in healthcare, and they reported, your lab results. And they're received in a central laboratory. And then the labs were then released in the computer or printed out for you. And it was great because there was no disconnect, like, okay, I'm going to run my lab here, and I'm going to perform my own smear, and I'm going to send it to this tech, and maybe I'll get it back, or I drew blood here, and I got urine there, but it doesn't go to the central system. And then you're not repeating labs either, which is really nice. And then everything's being released through one centralized system, so you're not waiting to get all your lab results from all these different areas and then to look at trends, right? Because you're not just going to look at a CBC without maybe a liver panel and a hepatitis panel when you're trying to look for maybe hemolytic anemia due to hepatitis, something like that. Or just in general, you want to look at someone's urine and renal panel at the same time when you're considering what's going on with their diabetes. Radiology information system is obviously so great. One, because radiologists can read imaging in real time from the computer and communicate back. And then we can store these vital patient care support data. So it's really nice when somebody gets an EKG and we store it, interpret it, we store it within our system, and the next time we get an EKG, you can compare them both on screen, which is really helpful, and you're going to improve just expedite of care. So managing data in healthcare systems. So literally, it's a warehouse. We think about those U-Haul storages. Many organizations aggregate data in a warehouse for the purpose of mining the data to look for new trends and new relationships. So a single comprehensive database facility communication among and helps to maintain compliance with privacy regulation, and it also helps you pull the right data based on search terms so you can look at trends. So data warehouse is an extremely large database or repository that stores all of an organization's or institution's data and makes this data available for data mining. The combination of an institution's many different databases that provides management personnel flexible access to data. Data marts. This is a collection of data focusing on a specific topic or organizational unit or department created to facilitate management personnel making strategic business decisions. And it could be small as a little database or a compilation of databases. And you can go mine them within that data mart. So it's pretty interesting. So data mining, I've been using this word. This software helps you sort through data because you're not just going to pull screens and screens. It's going to help you pull data based on a specific pattern criteria and then look for relationships. And the software can actually constantly be reading data mining on its own and help discover or uncover previously unidentified relationships. So you can set the criteria. It can also do self-mining, but it's really cool. So for example, I had a colleague who is getting her DMP, and she came in and she really wanted to look at just strokes in our patients. And unfortunately, we just didn't really have a lot of documented stroke, not because people weren't having strokes, but maybe it was just getting overlooked because it was diagnosed in a different area. It just, for some reason, wasn't on everybody's patient history. But we were able to set some criteria for stroke risk factors, and then kind of narrow down who we would research, and then figure out if they've had strokes in the past, and then based on that, make relationships through trends that were similar to them. So, we looked at hypertensive, African-American females who smoked over the age of 45, and we added in diabetes. And then we were able to go from 3 million data points to 500,000. And then from there, we went, we pulled recent hospitalizations, ED follow-up, and we were able to narrow that down. And then, from there, we are able to call their history. So it made things pretty interesting to be able to pinpoint who is at risk, and then whether we can start an intervention. So departmental collaboration and knowledge information exchange. Knowledge exchange is the product of collaboration when sharing and understanding of information. It promotes learning from past experiences to make better decisions in the future. And at an administrative level, collaboration among key stakeholders is critical to the success of any project. So from collaboration comes the exchange of information and ideas through knowledge sharing. So some thought-provoking questions. Just get a sip of water here. All right. So what type of technology exists today that can be converted into new types of information systems to be used in healthcare? How could collaboration and knowledge sharing at a single organization be used to help individuals prepping for information technology at different facilities? So, and then discuss the administrative information system and their applications. So, things I want to leave you with. I mean, even when this book was published in 2012, this edition, a lot has just changed in the last 4 years in terms of informatics, like boom change, right? We interface now within EMRs. I think things to work on are if we have different EMRs regionally, our ability to interface and exchange information stops quite quickly. So, everybody in Cincinnati in the health groups are Epic, including Cincinnati Health Department. But like a lot of the other FQHCs, they use cheaper EMRs that are still good, but we can't access their care. And so that makes it tough if someone goes to Crossroads or to WinMed, I can't get their information. So that's something to consider. And then collaboration and knowledge sharing, or technology that exists today. So telemed, right? We can FaceTime with collaborators. We can form video conferencing for mental health. How great would that be? Because there's such a mental health shortage. And then discuss administrative information systems and their applications. So, the case management systems, ways to improve financial. And oftentimes I think we kind of double chart on things. And so looking at where we can scale back so that we can free up time
and be more efficient.